Good morning, everyone, and thank you to the McKernans for providing such an incredible platform to share amazing information. This has been an incredible event so far. So my name is Deb Kimless. I'm an anesthesiologist and pain medicine specialist. I'm also the medical director of Forward Grow, which is a medical cannabis cultivation company in Maryland. We were awarded a stage 1 license to cultivate cannabis in Maryland. And we're busy doing our build out so that we can be inspected and create medicine for the patients in Maryland. But my passion and my love and what I do, and I think what I live for, is that I am currently treating over 100 patients pro bono. Actually, I'm medically guiding them in concert with their treating physicians using medical cannabis. And when I do this, we define benchmarks, we define goals, because everybody's goals and everybody's benchmarks are different. I take that information and I share it in conferences such as this, medical grand rounds, healthcare professionals, patients, and pretty much anybody that'll listen to me. So thank you for listening to me today. Today we're going to discuss four cancer patients, and each of them different, but each of them have some things that are similar. In addition to having cancer, the desperate desire for hope is that they were all treated with a very low dose cannabis oil extract. Some people call it a microdose, and I'm going to talk about what that definition means. So in the circles of, in the context of microdose in the cannabis industry, it doesn't, different than in science industry, mean 10 to the -6. It means a very low dose, because medical cannabis, I think, comes from the recreational or adult use size where people are using very high doses or amounts. And so we're going to do a little bit of math here, I apologize. So if we take a joint, which I hate that term, and if it weighs about a gram or 1,000 milligrams and 20% of it is THC, you end up having about 200 milligrams in that dosage form. About 30 to 40% of it goes up in smoke, literally. And if they consume the entire dosage, it ends up being about 60 to 80 milligrams. The low dose or microdose cannabis that these patients all took was literally less than 2 milligrams per ml, and we'll go into it a little bit more specifically. So this is their dosage form. In 1 ml, half of it is in the acid form or the raw form. Half of it is in the decarboxylated or neutral form. It has a 10-to-1 ratio of the THC or THCA to CBD to CBDA. It also has the minor cannabinoids and some terpenes in it as well. And they take a varied amount of doses depending upon what the condition is to treat. And there's a rationale behind it. Legrestier et al. In 2006 published this chart, which was very nice, and it shows the micromoles of THC, of all the cannabinoids in its acid and neutral forms, and what it does to the IC50, which is the inhibitory concentration where 50% of the cancer cells don't grow. And what does that mean in English? Because I had no idea what a micromole means in life. Is that if you use Avogadro's equation, and I was absent that day, so I actually used the help of a friend, to convert micromoles to milligrams, and even at its highest dose of THC, it ends up being 12.5 milligrams, which I think we can all agree is a lot less than the 60 to 80 milligrams. And I think the thought is, and what we probably heard over the last day and a half so far, is that we want to keep the med in medicine, the minimal effective dose. You can always titrate higher, but we want to see what we can do with the least amount. So we're going to talk about two cases of patients with prostate cancer. So the first is a gentleman, 72 years old, who came to me with recurrent prostate cancer. He was diagnosed in 2011. He had a Gleason score of 8, clinical state of T2B, and a PSA of 7.2. He was successfully treated with hormone deprivation with Lupron injection, seed implant, and radiation therapy, and his PSA dropped to 0.3. He was doing great for about 4 years, and then his PSA started to rise again. And they monitored him over 10 months, and in August, his PSA level was 7.8, and that's where he came to me. Ends up that his CAT scans, thankfully, and bone scans were negative for metastasis, and he wanted to do some help, get some help. So when he first saw me, he began the first of his 3 Lupron injections. His PSA after a month was still 7.8. We started a program of low-dose cannabis oil, 1 milligram sublingually, 4 times a day. We changed his diet, and then he continued this regimen for the 2nd and 3rd Lupride injection. And so I just want to show you a chart that shows on this level is PSA level, that was our benchmark, and this is time in months. So this is his first month after his recurrence where he got a Lupron injection alone, and his PSA was 7.2 or 7.8, I'm sorry. Second month when he came to me, we continued his Lupron and gave him the microdose of cannabis oil sublingually 4 times. And after that, a month, we redrew his PSA, and it ended up being 4.8. Third month, continued the same regimen with the Lupron and the cannabis oil. It dropped to 0.3. Fourth month, no more Lupron. They only get it 3 months in a row. Stayed stable. Fifth month, 0.2. And literally while I was standing in the back getting ready to give this presentation, I just got a text from him. He got back from Italy with his wife, and his PSA remains consistent at 0.2. 81-year-old man who is otherwise healthy, was diagnosed with, had some back pain issues, workup revealed a metastatic prostate cancer. He was treated with seed implants, radiation therapy, and the Lupron injections, and his markers were escalating testosterone levels, and they wanted to do surgery to remove his testicles to try to ablate the rising testosterone that was fueling the cancer. So he came to me with the hope that perhaps he could avoid surgery. So here we are. Testosterone is our marker here. It was as high as 1350, and over the weeks, we started at week 0 to week 2. In 2 weeks, 1 ml 5 times a day sublingually. It dropped 500 points from 1350 to 850. His surgeon said, that's great. We still think we need to have surgery. He goes, give me 2 more weeks. In 2 weeks, his testosterone level dropped below like what would be even seen in a normal level, and it continues as such to this day. And there are studies that show that this is not a surprising result for these prostate cancer patients, including a study that shows the androgen-reducing effects of cannabinoids. So brain cancer, 2 patients. So we have an 8-year-old girl with acute lymphocytic leukemia. She failed multiple chemotherapy trials and multiple radiation trials. She had a bone marrow transplant that lasted about a year and then no longer was successful. And she was placed in hospice. And her mom and dad came to us wanting some hope to see if we can help her out. Chief complaints for the little girl was chronic nausea, lack of appetite, severe headache, and lack of energy. And upon evaluation, when we saw her, she was very somnolent, non-communicative, and her face was swollen, her eyes were swollen. And because she was on hospice, the medicines that she was being treated with was methadone and morphine on divided doses. Actually, so we talked about goals, and the goals for her was that we hoped that we would reduce her opiates so that she can start eating and actually live out her last days in life, being an active participant in her world. And so this is her MRI in February 2015. This is a leptomeningeal spread of her cancer, including her ventricles. And so improved quality of life, trying to help her with her pain, and transition off of opiates. So we treated her with 1 ml of the cannabis oil extract 4 times a day. And by the way, this stuff tastes like cannabis. It's not flavored, it's not treated, it has no sugar component, it tastes awful. And this little girl of 8 years old sat and watched her cartoons with this under her tongue without a complaint, which I found incredible. So the initial response was that they started to slowly reduce her narcotics and then replaced it completely until she was off of all of her opiates. She became more active, and she had the appropriate demeanor of an 8-year-old. So for any of you who are parents out there, you would recognize this as back-talking, not listening, refusing to take a bath, and I think eye-rolling was involved. And the mom recognized that this was not the normal behavior of an 8-year-old who was dying of cancer, and she, even though they were on hospice, insisted on another MRI. And so there was... And there's still, some cancer, leptomeningeal spread here, but you could see the ventricles are cleared and everything else was cleared. This is just a comparison. And again, this is no surprise. There are studies that show ALL and other leukemias being treated with cannabinoids of all sorts, either CBD, THC, or in conjunction. And in fact, this last case is a case study, Singh et al., that described a case very similar to the one that I just described, who was put in hospice, was treated with a whole plant extract of cannabinoids sublingually. She went into remission, and unfortunately, in this particular patient, she died of perforated bowel. But for our case, she's still alive. 2 years later. Same dose. So history, here's an otherwise healthy 69-year-old man who presented to the emergency room post-ictal. He had a grand mal seizure, and he woke up in the ER not knowing what was going on. He had an MRI that revealed a tumor, a biopsy diagnosed with a glioblastoma. His chief complaints were lethargy, inability to perform his activities of daily living without assistance, and he was a big guy. He was 6'4", and his wife was a small lady, and she was really struggling, trying to just get him dressed in the morning and feeding him. He had cognitive changes. Here was a guy that prior to the surgery was active. He was an insurance salesman. He was on the computer. He rode his bike and interacted with his kids. All of that changed. The only medicine that he was taking was the Tegretol for seizures, and that was it. And that's his tumor, and it's in a really bad area. That's basically in the corpus callosum in the center of his head. So it was inoperable. They did a biopsy, and the one drug that was supposed to help with glioblastomas, Temodar, it was tested not to be good for him. So he was supposed to see his oncologist and get set up for radiation therapy, but somehow he saw me first, and we started him on a low-dose cannabis oil 4 times a day sublingually. Now, he complained. He hated this stuff and didn't want to do it, but his wife literally wrestled him down and made him do it, and did the Mary Poppins, a spoonful of sugar after it was done. So when he's done, he got a mint, and he was happy with that, I guess. And so the goals were to improve the quality of his life, improve his function, and with the hope, because there's lots of stuff out there that says that it can help with glioblastomas. His wife desperately wanted to reduce the tumor growth. And in the first 2 days, he started feeding himself. At the end of the week, he was on a computer. And somehow, and I didn't order it, somebody ordered an MRI 2 weeks later, and if anybody knows how difficult it is to get approval for any MRI, I have no idea how this happened, but the radiology report said evidence of central cystic degeneration, clearly responding to radiation. But there was no radiation at all given. And here's a side-by-side response. Now, he did go for radiation therapy. They did treat him with Temodar, even though it was not indicated. I guess and far be it for me to make these judgments. I mean, if I had this in my head too, or my loved one, I think I would throw everything at them. He was treated, his last treatment was in September, and I'll show you what he looks like now. But again, there are studies that show that these things work. And so this was last week. You still have evidence of it, but it didn't grow. So I'm not saying that we're curing this. I'm saying that we're managing it. He's in Florida. He just rode a bicycle with his wife. They are celebrating an anniversary, I know. They went to some spa. I mean, they're living a better life, quality life than maybe many of us, certainly. Anyway, and this is our greenhouse that we're building out. It's 1 acre under glass. And I beat the clock, so if anybody has questions, I'll be more than happy to answer them now. Bonnie. Yep. So it's a proprietary extract of 5 different strains that they want to combine so they get as many of the terpenes in major and minor cannabinoids. It ends up being naturally a 10-to-1 ratio of THC to CBD, THCA to CBDA. Per ml. Some people get 4 mLs a day, some people get, it depends on what we're treating and how aggressive and what they look like, what their experience is, and we titrate it up. I mean, that's sort of the ultimate goal, because even though with this ratio, the majority of people don't feel any psychoactivity, I treat patients, 8 was the youngest, to 92. And the 92-year-olds say it just gives them a sense of relaxation, helps them sleep, but no psychoactivity in the high sense.
Do you know the terpenoid profile?
Nobody's ever tested it. This stuff is out of California, so I'm lucky that we have this.
Right. And then one more question. In patients that have had metastatic disease, are you seeing any of the metastatic tumors shrinking as well?
So in the patients with metastatic disease, I see them managed, meaning that their pain is reduced, their tumors haven't increased or spread, but I have not seen the mets disappear. Primary tumors, yes, but not the metastasis.
Do you think that the reason low dose is so effective is that it mimics the low dose of our endocannabinoids, and it doesn't affect our receptor, no downregulation, and that it keeps kind of the receptors the way they without changing?
I mean, that's certainly a possibility, right? If I had the answer, I would hopefully be getting a Nobel Prize somehow. But I mean, there's people here far more smarter than I am. But I think that, my thought is maybe it's helping us balance ourselves, allowing our immune system to do what it's supposed to do. I change everybody's diet to give them the maximum nutrition, to provide a milieu so that the endocannabinoid system can work as best as it can.
Hi. Conventional knowledge tells us that the cannabinoid acids don't cross the blood-brain barrier, but they do cross blood-brain barrier.
In pediatric patients, they clear-cut that it does because it stops seizures.
But is this an indication that, again, cannabinoid acids are actually, or should I say the cannabinoid acids can essentially be active and not necessarily the deactivated form, and they have to be activated by decarboxylation?
So I never understood the term activated or deactivated. I think cannabinoids and terpenes are all important in the chemistry of this plant and the healthful benefits that it can offer. I think when people use the terms activated, I think it means to allow it to become psychoactive. And so I'm wondering, and I'll posit this question to everybody out here, is that what everybody's talking about? It's trying to achieve a psychoactivity, but I still think that the acids provide a healthful benefit to people. And I've seen it in over 100 patients. Yes? So that's a really great question. Again, we follow benchmarks. So for the patient who's been 9 months with a PSA now still back down to 0.2, we're going to start to slowly reduce him because I know that his benchmark is easy to follow. For the 8-year-old girl that is now 10, we're keeping her on a steady state dose because I don't know any better. And right now she seems to be thriving that way.
Oh.
Oh, no, these are just the easy ones. I have lung cancer patients, ovarian cancer patients, breast cancer patients. They have. If they follow the plan and they listen and yes.
Just, can I ask one more question? Have you
Absolutely.
tried higher dose to see if you can eliminate tumor completely?
So I think somebody said if all you have is a hammer, everything looks like a nail.
Yes.
So sadly, because we're limited in opportunity for consistency and profiling, this is the only medicine that I have access to consistently. And the beauty is I treat my patients pro bono. They get medicine free of charge as well. And so because of that, they're very open to trying it. And if it doesn't work, then I do make recommendations to go higher. But then our hands are tied as to what it is, because especially in legal states where they're out west, where there's not a lot of testing, it becomes very difficult to figure out what exactly they're getting and making sure they get it continually. But I would love to, and that's why I'm the medical director in Maryland, because that's my passion, is to make sure we have consistency, make sure we have opportunities to scale up if we need, because everybody's different. Not everybody needs high doses, and not everyone works with a low dose. Thank you, everyone.